Josh.
Sharon. How you doing? Good, how are you?
Doing well. Good afternoon, everybody. Thanks for being here this afternoon. We appreciate it. We're here today to announce an expansion of the Pinellas County Sheriff's Office Mental Health Unit because we need to handle calls involving people with mental illness differently. We've made some progress over the years in how we handle these calls. Law enforcement officers do, do a better job today than in the past in recognizing that some individuals' actions are a symptom of mental illness and that the acts that these people are committing are not true criminal acts. They're actually symptoms of mental illness. While we made progress, we can and we need to do better. If you look at the efforts over the last 20 years or so, the efforts have been to provide mental health training to law enforcement officers so that they can identify those in mental health crisis, assess them, and navigate them into the right services as opposed to arresting them, which is the way that it was done traditionally many years ago. However, trying to make cops mental health professionals is trying to jam a round ball in a square hole. It's not a good fit, and in fact, it really does not fit at all. I'm going to give you some background and then explain a significant expansion of the Pinellas County Sheriff's Office Mental Health Unit under a co-response model that teams deputies with mental health professionals to achieve the better result that we all desire. The co-response model is a team approach where cops and mental health professionals work together, but each stays in their own lane. As we're well aware, and sadly, there are a lot of people across Florida and right here in Pinellas County who suffer from mental illness and other disorders. Many people suffer from co-occurring disorders, behavioral health issues, mental illness, and addiction. The mental health system doesn't have the resources to meet the needs of all of these people. And as we know, and you can look at the data, it shows that Florida, being the third largest state in the country, is at the bottom in per capita funding for mental health. The Florida mental health system is a complex web comprised mostly of private entities funded by the state through what are called managing entities. And the biggest void in this mental health system here in the state of Florida is the lack of a dedicated case management system. Case management, especially master case management, is where a single case manager is responsible for an individual's care coordination and treatment so that they don't bounce around among providers without a cohesive objective that works toward solving a person's problems. Simply put, many people revolve in and out of the mental health system in our county, and they cross between the mental health system and the criminal justice system, meaning the jail, without anyone owning their problems through master case management. And this creates a revolving door that so often ends in the problem on a law enforcement officer's lap at 3 o'clock in the morning when the symptoms of mental illness has caused that person to act out and sometimes to commit a crime. Under the current system, this is where the problem gets worse because the people who are least qualified, and I want to stress that again, the people who are least qualified to address the mental health issues, which are the cops, are being called upon too often to deal with the symptoms of mental illness, and criminalizing the symptoms of mental health disorders is not the way this should be handled. So asking a cop at 3 o'clock in the morning to do a differential diagnosis, figure out solutions to an emotional crisis that caused someone to lash out is unrealistic. And it's really setting the cops up for failure, which is unfair to the cops, and many times setting the person up who's suffering from the mental illness for a ride to the county jail or to a Baker Act facility. Now, there's no doubt that cops over Baker Act, and that is because they are not skilled mental health professionals with clinical training to identify when a person really needs an involuntary exam or when they can remain at home with services. In many cases, an arrest or a Baker Act accomplish nothing toward actually solving the underlying problems. It simply solves the instant situation so the cop can go on to the next call. A Baker Act is a short-term solution with minimal impact because the person is released from the crisis stabilization unit, the Baker Act receiving facility, in a matter of hours, again, with no master case management or solutions to what started the whole incident to begin with. There's very little effective discharge planning from Baker Act facilities. Now in Florida, when you look at the numbers, it's pretty staggering. There are about 200,000 Baker Acts done each year in the state of Florida, with about 11,000 Baker Acts here in Pinellas County. And about 50% of those are done by law enforcement. The Pinellas County Sheriff's Office responds to about 5,000 mental health related calls a year. Some result in Baker Acts, some result in arrests. Now, we said that the cops receive little mental health training in the police academy. It's only about 16 hours. That's it. Some law enforcement officers have received crisis intervention team training over the last 20 years. And that's a 40-hour course of instruction that provides some tools to the officers to better identify mental health issues and deal with them more effectively. But that training is limitedly available. And today, here in the Pinellas County Sheriff's Office, of our 550 patrol deputies, only 25% are CIT trained. Due to class availability and size limitations, we only trained 25 deputies in CIT in 2018 and 16 in 2019. None have been trained in 2020 due to COVID, and there are no classes currently scheduled for 2021. While we continue to lose those deputies who are CIT trained to retirements and transfers to other areas of the agency. So we're going backward, we're not going forward, we're not making progress with this training. Because of the void in CIT training, we have provided an 8-hour mental health first aid class, and about 38% of the patrol deputies have attended that training. Now, I've heard for years, like we've heard over the last few months, calls for more mental health training for cops. Now, some training is needed and it's beneficial and it'll help the officers reach a better result. But we really need to ask the question, are we being realistic in these suggestions, these calls, these demands for more training? Are cops really the ones that should be tasked with doing mental health assessments and directing people to services? Is this training really going to drive the change that we're looking for? As I said for a long time, the answer to those questions is no. After years of speaking about this void and seeing that the mental health system was not going to fill it, back in late 2016, we started the Pinellas County Sheriff's Office Mental Health Unit. Now, the original plan for that unit was the co-response model, one where a cop and a mental health professional would team up, respond to mental health calls, with each bringing their skills to jointly address the situation for a better result. We contracted with a local mental health provider to team deputies with licensed clinical social workers to respond to these calls in a pilot area. And that pilot area was generally the Lellman area, north of St. Pete, south of Pinellas Park, and that mid-Pinellas County area. For a number of reasons, that pilot really wasn't successful. We had a number of challenges, and it really didn't get off the ground. We transformed the mental health unit into a case management function where the unit of deputies and mental health professionals did not respond to those active calls as first responders, but they followed up with people who had been released from Baker Act facilities and identified others that would benefit from follow-up services. So what we were doing is, in essence, bringing a version of that case management to the street. We're trying to fill that case management void that did not and still does not exist. Now, these mental health teams have and continue today to contact about 160 people a month for follow-up. The model was working between 2016 and 2018, but it still lacked referrals to a true case management entity, one where people could own the problem and get these people from where they were to a better place by intensive case management services. So in 2018, we formed the Pinellas Integrated Care Alliance, which is a collaborative effort of the Pinellas County Sheriff's Office, Pinellas County Government, the Pinellas County Health Department, and the Central Florida Behavioral Health Network. We also received some funding from the Foundation for a Healthy St. Petersburg. The Alliance contracted with PEMS, local Baker Act receiving facility, to manage these, as we call them, PIC teams, Pinellas Integrated Care Teams. The PIC teams are staffed with 8 case managers from Baycare, PEMS, Directions for Living, and Suncoast Services. The Sheriff's Office Mental Health Unit refers individuals it identifies as a result excuse me, of law enforcement calls to the PIC teams so that these people are diverted from the jail, from the criminal justice system, and hopefully also diverted from the Baker Act system. Since July of 2018, the PIC teams have case managed about 350 people, and there are about 70 to 90 people at any given time that are being case managed and receiving services from the PIC teams. Now, a recent analysis of the PIC team clients shows that it's working. Test scores show clients are functioning better. There's a decrease in the number of Baker Acts, decrease in arrests, and a decrease in the days in jail for those participating. Now, this chart here to my right, to your left, is summary and metrics and data of the PIC teams. We can give you copies of that. That was an analysis that was done by the University of South Florida on the results since we established the PIC teams in 2018. So what we're announcing today is an expansion of the mental health unit and the creation of a true co-response model. So what we've done here with the PIC team and with the mental health unit is that we've established the back end or the foundation. We have case management and we have the follow through with the PIC teams. Now what we need to do is fill the void on the front end. The current mental health unit has a sergeant, a corporal, and 2 deputies, and 2 mental health clinicians who do this back-end work, do the case management, and refer the people to the PIC teams. The new expanded unit will have a sergeant, a corporal, a licensed mental health clinical supervisor, 6 mental health clinicians, and 6 deputy sheriffs. The mental health clinicians will be called crisis response specialists. The clinical supervisor and crisis response specialists will be Sheriff's Office employees and not contract providers. It's somewhat fluid, but it's likely the pilot area for this will be between State Road 580 in North Clearwater and Park Boulevard. The cities, the incorporated cities, they have their own police departments like Largo, Pinellas Park, will not be included, and even though it's a provider for ours, we're not going to include the city of Dunedin in this initial pilot. The initial phase of this, the teams will respond to calls 12 hours a day, Monday through Friday. They'll work from noon to midnight. We did an analysis of our mental health calls, and those are the peak periods for mental health calls between noon and midnight, Monday through Friday. Of the 6 teams, 4, and there's an organizational chart here to my left that lays this out. Of the 6 teams, 4 will be response teams. So that's going to be a deputy and one of the crisis response specialists. The call will come into the 911 center. It'll be screened. If it's determined that the call is mental health related, then the zone deputy will not respond. And the co-response team made up of the deputy and the crisis response specialist, they are the ones that will respond to that. 2 of the teams there laid out at the bottom will be doing the follow-ups, which is what they are doing now. And some of the calls that these teams will be responding to include everything from domestics to neighbor trouble to batteries when somebody hits somebody else. It's really a, you name it, if it involves mental health, that it'll get the response from the co-response mental health team as opposed to a zone deputy with no CIT training, 16 hours of training in the academy years ago. Maybe they had mental health first aid training, going out there like we've always done and trying to figure it out. So once the response team goes out, they're going to provide an initial assessment, and that'll be done appropriately to address the issues. And again, it frees up the zone deputy to focus on other law enforcement issues. The team members are going to bring their own unique skills and qualifications, and through that model, we stop trying to make cops mental health providers, and we don't create a situation where a mental health provider is trying to deal with a volatile and perhaps dangerous situation without law enforcement presence. The response teams will assess the situation, make a decision whether a Baker Act is required, and if not, then what types of services are needed and are appropriate. The response team will refer the matter, as I said, to one of the two follow-up teams, and they will be responsible for determining the level of case management and services that are needed, and if necessary, referring the person to the PIC team for more intensive case management and care. By having in-house mental health professionals respond with the deputies to these crisis calls, follow-up case management, and direct clinical supervision, we will have better outcomes that keep people out of the jail and out of the Baker Act system when they don't need to be there. Now, as we go through this, we'll assess the expanded co-response model over the next several months, tweak it where necessary, and look to expand it to other parts of the county and perhaps partner with other agencies within Pinellas County. We can treat people better and produce better outcomes while keeping them out of the jail and out of the Baker Act system, and that's what this initiative seeks to do. We're breaking the mold, and we're creating a different model, and we must do that if we want a different result. And I believe that we can all agree that we want a different result than what we see today, which is too many arrests, too many Baker Acts, when the matter could and should be handled differently. We've all heard the adage, if you always do what you've always done, you're always going to get what you always got. Today, we stop doing it the way we've always done it so that we get a different and a better result. So this is something that has been in the works for a long time. I'm excited about it. I really think it's going to move us in a great direction. And again, stop trying to cram that round ball in that square hole where we're telling cops, be jack of all trades, be mental health counselors, be this, be that, and solve everything, where they simply don't have the skill set to do it effectively. They're doing the best job they can with the tools that we've given them, but as agency heads and administrators, we haven't given them the right tools. We ask them to do things that they're probably ill-equipped to do, and we shouldn't be asking them to do it. So I think this is a better model. I know it's going to be effective. We've put a lot of work into it, and it's really been in the works in some fashion for the last 4 years. So happy to take any questions that anybody has.
So Sheriff, the new thing is the case management system and these extra mental health providers expanding the PIC teams. That's what's new.
Well, really what it's doing, Josh, is that we built the back of the circle, and we built the foundation. The back of the circle is that people are doing things, acting in a certain way because of mental health issues, because of behavioral health issues, because of addiction issues, or all of it together as a co-occurring disorder. When the cops go out today, across the county, across the state, across the country in many respects, is the cop that's dealing with that is going to do what cops do. And they are going to remove that problem from the situation so they can go on to the next call. And there's two ways they generally do that. Throw them in jail or a Baker Act. And it's not right, because those are symptoms, those actions are symptoms. And they're symptoms of mental health issues. These aren't bad people that are committing crime. These are people who are acting that way because something got in their head. It's uncontrollable. So what we're doing today is it's hit or miss. If they get Baker Acted, if they get arrested, or they don't do anything, leave them there. We today in the sheriff's office, because of the mental health unit, we're going out with the mental health unit, we're knocking on the door, saying, hey, what's going on? Can we provide you with services? Can we help? You're trying to figure it out. But that's not being done everywhere, because we're the only agency in the county that I know of that has a mental health unit like this that's doing it. And again, they're going out about 160 times a month. If the person is receptive to services, then they're referring them over here to the PIC teams, and they're doing this case management. But where we got a huge gaping hole is that when that call comes in originally, is that nobody who knows really what they're doing is going out and addressing it immediately. You got the cop going out, and the cop's either leaving them, the cop's Baker Acting them, or the cop's throwing them in jail. And what I'm saying is that in so many of these situations, and no fault of their own, cops are doing what they know to do with the tools they have. We haven't given them the tools. And so many times they over Baker Act. That person didn't need to be Baker Acted. That person could remain there with services. So if you have the response team and that mental health professional is more likely, because they're not in CYA mode, they're not in let me just clear this call and get out of here mode, they're in a mode of making a clinical assessment and the right decision, they're more likely to leave that person there because they can do a warm handoff to the follow-up team. The follow-up team will then go back and stay on it and assess the person or pass it off to more intensive case management. So what we're announcing here today is closing the circle and getting back to the front of the circle and filling that gap that's been there now for the last 4 years while we develop the backside. So that's really what it is, and it's huge because I don't know of any, I know there's no other entity in Pinellas County that's doing it. There's a few maybe in the state of Florida that are doing it, but we're making a big commitment to it, and one of the biggest commitments to it is that we're taking this in-house. We have a licensed mental health counselor who's an in-house clinical supervisor that's going to clinically oversee the mental health professionals to make sure that the assessments are being done correctly, the diagnoses are being done correctly, the services are being done correctly. We're getting these people, we're going to do staffings, and the deputies are there to deal with anything that needs to be dealt with and provide the safety and security and perform that team. What we've been doing for the last couple of years on the backside and case management will remain. You can't have the front end, what we learned, you can't have the front end without the back end, and the back end without the front end leaves this gaping hole. So we're filling the hole.
These crisis response specialists, are they already hired and within the Pinellas County Sheriff's Office, or are they contracted out?
So right now, we have 2, and they're contracted out. That contract with the provider ends on September 30th next week. So we have posted the positions, and we're in the process of hiring. We've hired 1, and we need to hire several additional ones. The deputies will be reassigned from current positions, so they're already here. And so the process will be is getting the crisis response specialists onboarded, getting the deputies assigned, and moving it forward. I think that we can get this up and running in pretty short order. We've already hired the clinical supervisor. The wheels are definitely in motion and moving this along.
So about 6 total.
For right now, correct, 6 total, plus a corporal and a sergeant in the unit. So it'll be right now a total of 6 crisis response specialists, 6 deputies, a corporal, and a sergeant. So 8 law enforcement officers and 6 crisis response specialists.
Sheriff, on a basic level, does this just provide some caseload relief for your deputies, like you mentioned, that are in those particular zones?
Well, it does. It will inherently, because they're not going to get tied up on these calls, and they can focus on, I'll call it, more traditional law enforcement things that they need to deal with, and have the people who are better equipped and will provide a better outcome deal with these things. So, but at the same time, the answer is yes, is that if they're not out there having to deal with this mental health issue, and these calls are time-consuming calls, if you do them right, and we want them to do them right, because a lot of times you got to sit there and talk to these people, you've got to do an assessment, you've got to develop a relationship, and then hopefully make a right decision. But I'll tell you, and I'm just going to tell you straight and honestly, is that a lot of these cops, and I was one of them years ago, is that you don't have the tools in the toolbox, is that you never received the right quantity and quality of training to the extent. And even if you're CIT trained, you got a lot more training and you're probably going to handle it a little bit better, but you're not a clinician. You're not a mental health professional. And a lot of times what they're trying to do is just figure it out. Am I going path A, leave them, path B, jail them, path C, Baker Act them, and which one am I going to do with those so that I got 5 calls waiting for me? And so that's not the way these calls should be handled. So at the same time, yes, it'll free up the zone deputies so that they can attend to other calls and other matters.
Can you say again where that pilot program is taking place, and when do you expect or hope to have it expand to the rest of the county? So
to the rest of the county, so we're going to get this up and running. Like I said, the wheels are in motion. It's in motion right now. And we're doing the hiring. We're going to get people onboarded. I would imagine in the next few weeks, we'll be in a position where the teams will start to roll out. We'll give it some time. We're going to do assessments of it. And I would imagine it will be after the first of the year that we'll take a close look at it, look at the data, look at the metrics, get the feedback from the people who are doing it, and see where we go. And I'll tell you that I've been able to put this together with what we have. And the cost of because we're bringing them in-house, so we have the contract with the local provider for what are now their mental health professionals, the crisis response specialists, and we're able to it's going to be about $650,000. There's no cost for the deputies because they're just being reassigned from current positions. So if we were to expand it, which I intend on doing, and I think that the success of this will establish, and one of the reasons why I'm so confident about it, because we've built this from the ground floor. We've learned from our mistakes. We've been through this for the last 4 years. And when we first started it out a few years ago, we bumped, we tripped, we didn't get it where it needed to be. And so we've learned a lot. And I know that this is the right people with the right model, and this is going to be successful. But to expand it further is going to require additional funding and probably an ask of the county commission as we move forward. But we'll cross that bridge when we get to it. But I don't anticipate that that'll be until sometime early next year.
And where's the 650 coming from now?
Well, some of it is because, again, we're saving money because we have canceled the contract with the provider and we're reallocating some operating money from some other accounts. So it's a combination of those things, which in the big scheme of things is really not that much with what we're doing to put together what are really 14 people to do this. So it's really being done economically with what we have.
Just want to ask you a final question, off topic about the Breonna Taylor Grand decision that came out about an hour ago. I know one of the 3 officers was charged with 3 counts of wanton endangerment. Just to get your response to, this that everybody had been waiting on.
Yeah, well, and I understand, and there's so many things about that case. We talked about it before when I did the press conference before about the change in how, by policy, how we're not executing those type of warrants. We're not doing the dynamic entry warrants. That situation in which that officer was charged was because he fired a number of shots in the adjacent apartments and just kind of wildly fired. That's what's been reported today. That's what the Attorney General in Kentucky announced as the basis of the charges. So, that isn't because of the shooting of Breonna Taylor. That's because of him, I guess as they worded it in Kentucky, recklessly, wantonly firing, negligently firing, if you will, into the adjacent apartments and endangering others. So that's the nature of the charges. And the grand jury didn't return charges against the officers for anything to do with the entry or the shooting. And as I said before, it's a very, very tragic and unfortunate situation. And I'm a staunch believer in and an advocate for risk mitigation. And the way we do things here is not the way they do things in Kentucky, apparently. And I told you before, is that we started this here many years ago. When we serve search warrants, we make every effort to serve that search warrant in the safest way possible that mitigates the risk of harm to others. And that includes a lot of pre-surveillance, knowing who's there, who's not, and trying to take the person off while they're not in that house. And my goal is, when we serve search warrants, is to serve those search warrants when there's nobody in that house, because that's the safest for the law enforcement officers and it's the safest for the people who occupy the place where we're serving the search warrant. And yes, even if they're, quote, bad guys, even if they're dope dealers, and dope dealers need to be held accountable, and drug traffickers need to go to prison. But in my view, and people disagree with it all they want, there's no amount of dope that's worth somebody getting killed over. I don't care if you're a cop or you're a bad guy, is that there's no amount of dope that's worth somebody's life. We'll deal with you. We're going to put you in prison. We're going to seek you out. We'll be aggressive in going after you. But we're going to make sure we do it in a way that is as safe for everybody as possible. And I don't think it's worth somebody getting shot and killed over. So it is what it is. They've made their decision up there. People should respect the decision in the grand jury process. And let's continue to look for ways to do it effectively and safely.
Lastly, Sheriff, you guys investigated the St. Pete case recently, and that involved mental health and a death. And can you talk about that? I know it's a different agency. Right. You guys investigated. Do you want to say anything about that?
Well, I think, Josh, I have to be careful about that because under the new task force concept, I was responsible, and the Pinellas County Sheriff's Office was the lead agency in that investigation. You saw the letter, and it was referred to Chief Holloway in the St. Pete Police Department, and it's under active internal investigation in St. Pete. So I should be careful about making any comments about it, but I'll say this, is that a situation where there are repeated calls to a location over an extended period of time with somebody who is exhibiting clear signs of mental illness and somebody who has been acting out are the classic example of where we can and we need to do it better. We need to connect the dots, and we need to engage in case management, and we need to do it differently than the way we've always done it. And I'll tell you, though, that from what I know, and I know a lot about it, is that situation that occurred in St. Petersburg, that situation could have happened in any agency, including the Pinellas County Sheriff's Office. Why? Because we're not giving the cops the right tools to get the result that we want. And that is, we're asking them to do too much. We're asking them to do a differential diagnosis, to decide the treatment options, to get these people into the right lane, because they had 16 hours way back in the day of police academy training. If they're lucky enough, they went to some 40-hour CIT class, or maybe they went to an 8-hour mental health first aid class, and we expect them to go into these situations and connect all the dots and deal with somebody with severe mental illness. It's an unrealistic ask. So we, all of us, need to do it differently and better. And I think that any agency could have a less desirable outcome in an incident unless you break the mold and you figure out a better way to do this. And I think that can apply to all of us. And you know, I know it can. And I say this again and again. The cops are trying. They're doing the best they can. We haven't given them all the tools they need. And CIT is a good thing. I think CIT is fantastic. But it's a small tool in the toolbox. And again, you're asking people to do something they're simply the least qualified to do. So let's get the qualified people out there with the cops, bring them together, and they all bring their skill sets. They all stay in their lane. They complement each other. They work as a team. And hopefully, situations like the St. Pete incident, situations that we've had, situations that other agencies have, hopefully they don't happen again. And we got a ways to go, but we're putting it on the course to get there. Yeah.
Simple question, but just put it into perspective. 16 hours of how long are they in police academy for?
About 20 weeks. And I'm being generous with that. Now, I wouldn't even consider all that, but that's what they call it. That's what the Criminal Justice Standards and Training Commission would probably tell you when you look at the curriculum, that 16 hours of it is related to mental health. And I think that's a generous attribution on top of everything else. And for many of them, that's years ago. Well, they're learning everything else. You cannot expect that you're going to have somebody go through the police academy, get 16 hours of this training, and go out and handle these calls the way they need to be handled. It's just not going to happen, you know. And so what do? Jail them, Baker Act them. Jail them, Baker Act them. And then what happens? They get on the hamster wheel, on the revolving door, because there's no effective discharge planning from the Baker Act facilities. There's no case management. They go right back out until when? Oh, the cops get called again. Then what do? Do the same thing over again. Then what happens? The cops get called out again, and they do the same thing over again. Does that sound familiar? You read that letter? So that's where we are. Same thing in the jail. They get charged with a crime. Charging these people with a crime is not accomplishing anything. And probably a lot of the time, the state attorney is not going to file the charge. They probably shouldn't file the charge. And even if they do file the charge, nothing's coming of it anyway. So where are we? Who's owning the problem? Somebody needs to show some ownership. This is ownership. This is saying that we're going to do something not just to treat it, but we're going to do something to try and solve it. You can't solve everything, but let's at least make an effort to get it somewhere other than where it is today. Let's do it differently. That's where we are. All right, thanks everybody, appreciate it.